My name is Joelle Wagner. I'm a physician assistant. I've worked here a little over a year now. Prior to this, I worked with neurosurgery for 4 years. I've been working with patients with SI joint pain for 5 years. So typically, to rule in or out SI joint dysfunction, a lot of times it's a good history and physical. A lot of it comes with experience as well. Typically, a lot of our candidates are people who have had prior lumbar fusions and present with pain that is differing or down the line from their fusions. It's in their butt, going down their legs. Sometimes it's into their groin, their low back. If it does go down the leg, I find typically not below the knee, but it can. A lot of it, like I said, is kind of just a history and physical and ruling in and out other sources of pain. You do have to rule out their hip for sure because the pain patterns overlap. So far in this practice with this procedure, our patients have been doing very well. We have a good success rate. People find relief pretty quickly, I would say, after the procedure, within a few days. Some people are sore about a week or so, but then notice gradual improvement during that week. They come in a week later and I take the stitches out, so it's a good touch point. Again, a lot of this comes with experience. If I were to go back 5 years, I would say don't rule out SI joint pain. It really is kind of a diagnosis of exclusion where you're excluding other things, but definitely keep it on your radar at all times. There's more people that have SI joint pain than you think. I'd say females in their 40s to 70s are good candidates. Anyone with prior trauma, falls, previous lumbar fusions. These are all people you should really be thinking about SI joint pain. A good question to rule it in and out is what makes it better or worse. Typically, these people are worse with going up and down stairs, bending, prolonged walking, standing. A lot of times you can tell just by how they're sitting in their chair. And then to make things better, a lot of times it's just the patient being in a neutral position, laying flat on their back, not putting any weight or pressure on their SI joints. People will say when they roll over or move in bed, it makes it worse, and we'll wake them up from sleep. That's another indicator. Start thinking about SI, getting in and out of a car. So a patient that has true SI joint pain, a lot of times when you walk in your room, you'll see they're sitting in their chair and they're trying to offset the pain and sit on the side that doesn't hurt and kind of not put any weight on their side that does hurt. So you'll see them kind of leaning, sitting, legs crossed, just really trying to avoid putting any weight on that side.
Okay, first we're going to do is center over the proper SI joint. We're doing the right one on this one. Your normal angle is about 15 to 20 degrees, counterlateral to the SI joint. If you use a cephalic or caudal angle, it's 5 to 20 degrees. We're going to take a centered image, and then we'll go over counterlateral to open up that joint. Okay, this is when it sometimes will close up on you. So we're going to go back the other way. About there. It looks like we're at about 18 degrees. Nice open joint in the middle. Right here's your SI joint. You have your posterior and anterior marks where they cross right in the middle. And you want PSIS just out of the way, and that's this line here coming from the top. This is your posterior and anterior lines for your SI joint, and where they cross is normally where we're going to aim for. That's a little high, so I might need a cephalic angle on this one. Normally we wait and ask the doctor what her opinion is once she gets in here if you run into something like this where the joint's not completely open. We don't use a caudal or cephalic angle. We used to. This just seems to make it easier to get in and less chance that we're going to hit the bone trying to get the pin into place.
This so they can see how it looks on the inside. And then you take it out like this.
do that for next case. Little Pog, okay? Okay, sorry, Donna.
So and the other instruments.
Donna, are you okay?
Yes, I'm good, thank
Cool.
you.
This sound I don't like because it's a very deceiving. Yes, I use that hammer. This one doesn't sound. Yes.
Check it out.
所以它上面搞的。
Okay.
Margie, say something.
Putting in that separator now.
Okay, I feel that.
Okay, so now this is where you're gonna feel the taps.
Okay.
Good.
You're doing great.
Yeah.
I know.
Stay short.
And now we're gonna put the next instrument in with the short side to the.
Make sure she will back into the light.
If you need more numbing, you just ask for it,
Yeah, I
Donna.
do.
Sure. Yeah. Okay.
So this is the decorticator going in,
Okay,
like we were just talking about.
right.
This should just be a lot of pressure.
Okay.
And then the implant's going in a minute here, and we're all done. You're doing great.
Good.
Here comes the last bit of pressure.
Okay.
Implant's going in right now.
Oh, good. I was very excited for this.
Great. So everything's coming out. It looks perfect.
Oh, good.
Say that. Beautiful. This is the perfect one.
Well, I'm sorry I had to take that other shot.
No, you are fabulous.
Do
No.
you want me to go to
You
the
didn't
spa?
even use.
It was a lot easier than I expected it to be. You know, the pounding, I didn't even realize. I said, when do the stitches start? And she said, I'm already sewing them on the inside. So to me, it went great. And I swear I feel better. But she said, well, don't forget, you have pain medicine. And, you know, when you get home, it might be different later on. And I have the ice for it. So I'm not worried at all. I'm really excited. I really do feel 100% better. My procedure was 5 minutes ago.
And how are you feeling?
Great, just great.
You can
Yes.
walk?
Oh yeah, yeah.
Excellent.
I feel good. No dizziness, no anything, no soreness.
Okay. Are you ready to go home?
Yes, I am ready to go home.
Great.